I'm Tiziana Aranzulla from the Mauriziano Hospital. We are going to discuss the CARUSO study. We know that Evolocumab is associated with favorable outcomes in patients with coronary artery disease, but little is known regarding carotid artery disease. We know that Evolocumab promotes coronary plaque regression, but we don't know the true impact on carotid plaques. Indeed, only a few case reports and small randomized trials are available, and this is the background of the CARUSO study, which aimed to evaluate the impact of Evolocumab on top of optimal lipid-lowering therapy as compared to lipid-lowering therapy alone on morphological stabilization and carotid plaque regression to see if we can find the same results as in the coronary landscape. So we randomized the patients with carotid artery stenosis more than 50% to optimal lipid-lowering therapy alone or to Evolocumab on top of optimal lipid-lowering therapy. What is important is that we upgraded the lipid-lowering therapy to rosuvastatin 20 plus ezetimibe 10 milligrams in all the patients. And on the same background, we put in the Evolocumab arm also Evolocumab on top of this optimal lipid-lowering therapy. We enrolled 170 patients. After randomization, 5 withdrew consent before receiving any therapy, and therefore the study analysis included 165 patients with 175 carotid plaques. And we followed all these patients with carotid duplex ultrasound at 6 and 12 months in order to evaluate the impact on the primary endpoint, that was morphological stabilization at 6 months and or plaque regression at 12 months. Morphological stabilization was defined as the shift from high-risk morphological types that are carotid plaques with high percentage of hypoechoic areas, and low-risk carotid plaques are those with or uniformly echogenic plaque or less than 50% hypoechoic areas. Carotid plaque regression was defined as the reduction by at least 5% in the percentage of carotid stenosis and or reduction of peak systolic velocity by at least 5%. Key findings are 3 types of findings. The primary endpoint was achieved numerically in a higher rate in the Evolocumab arm as compared to the statin arm. But what is very important is that Evolocumab reduced morphological deterioration, that is the opposite shift from low-risk types to high-risk types. So while it promotes a numerically higher rate of morphological stabilization, it also halved the morphological deterioration. This is very important for our patients. Secondary endpoint was LDL-C absolute and percentage reduction, and it was achieved significantly in a significantly higher rate in the Evolocumab arm. But what was very important and was a striking result, and that is that Evolocumab reduced adverse vascular events by 7-fold at 1 year. And this is very important because Evolocumab was the only independent predictor, the absence of Evolocumab was the only independent predictor of adverse vascular events, with a number needed to prevent one event of only 8. This is a striking result, and it can change the management of a patient with carotid artery disease because according to these findings, Evolocumab should become the standard therapy, irrespectively, regardless of the morphological type. Because what we saw is that also benign, let's call them benign, morphological types at enrollment can shift to high-risk types, and Evolocumab prevents this shift. First take-home message is to improve awareness in this patient cohort that is at ultra-high risk. So we found that at an enrollment, only 29% of patients were on full dose statins. That is confirms the severe undertreatment of these patients despite the guidelines recommendation. Plus, if you add Evolocumab to optimal lipid lowering therapy, you can reduce by 7-fold your adverse vascular events at 1 year. So this is a very important message for all the interventional and non-interventionalist community, because can help to prevent many events, and also to keep in mind that these patients have a very high risk, and guideline recommendations are clear, but clinical practice nowadays, it's not in line with the guidelines recommendation. First, to have larger studies, because although the CARUSO studies is the largest so far, the numbers are still low. So I would like to see larger studies on this topic, and also larger studies may be focused only on patients who already had an event in their past or without any other cardiovascular risk factor, in order to give us other clues to implement our therapy.